The supraventricular tachycardia. Definition. Supraventricular tachycardia is a condition presenting as a rapid heart rate originating at or above the atrioventricular node. Supraventricular tachycardia can be contrasted with the potentially more dangerous ventricular tachycardia.
Supraventricular tachycardia, also called SVT, is a relatively common diagnosis in the pediatric population. It's estimated that about 1 in every 1,000 people will have SVT. If SVT is diagnosed before 1 year of life, there's about a 50% chance that it could spontaneously resolve. However, if it is diagnosed after that age, then it is unlikely to resolve. Supraventricular tachycardia generally has symptoms such as palpitations, often with a sudden onset of fast heart rate, shortness of breath, sometimes dizziness, and occasionally patients can have fainting episodes. In some patients, these episodes may be associated with exercise, activity, or with caffeine. Supraventricular tachycardia occurs due to an abnormal piece of muscle in the heart allowing electricity to loop. This loop of current causes supraventricular tachycardia.
To show you an animation of a common type of supraventricular tachycardia, follow me to this bossis.org animation. Normally, the electricity in the heart starts at the sinus node. This electricity then passes through the atrium to the AV node, seen here in the middle of the heart. The AV node is a bridge between the top and bottom chambers of the heart that acts like a toll bridge. It receives the signal and sends it to the ventricles. In a common type of supraventricular tachycardia, an electrical signal passes through the abdominal muscle within the heart, causing the heart to beat quickly. This extra muscle, in this case seen as accessory pathway, can allow electricity to loop back again to the atrium and return to the AV node. The AV node passes the signal back to the ventricle, which can again loop back to the atrium through the accessory pathway and again to the AV node. As you can see, the heart is no longer under control of the sinus node, but under this loop of current. This can cause the heart to beat at over 200 beats per minute. This is what's called supraventricular tachycardia.
Ties. The ties has sinuatra origin, sinuatra nodal reentrant tachycardia, atria origin, ectopia atria tachycardia, multifocal atria tachycardia, atrial fibrillation with rapid ventricular response, atrial flutter with rapid ventricular response, atrioventricular origin, AV nodal reentrant tachycardia or junctional reciprocal tachycardia, permanent or persisting junctional reciprocal tachycardia, a form predominant in infants and children but can occasionally occur in adults. AV reciprocal tachycardia, visible or concealed, junctional ectopy tachycardia. Application en medicina. The signs and symptoms. Symptoms can arise suddenly and might resolve without treatment. Stress, exercise, and emotion can all result in a normal or physiological increase in heart rate, but can also more rarely precede SVT. Episodes can last from a few minutes to 1 or 2 days, sometimes persisting until treated. The rapid heart rate reduces the opportunity for the pump to fill between beats, decreasing cardiac output and as a consequence blood pressure. The following symptoms are typical with a rate of 150 and 270 or more beats per minute. Heart pounding heart, shortness of breath, chest pain, rapid breathing, dizziness, loss of consequence in only the most severe cases.
Symptoms of supraventricular tachycardia or fast heart rhythm actually can be very, very variable. We have pediatric population that will go to their parents and say, mommy, my heart's racing away, or mommy, I'm short of breath. Well, often that gets even written off as anxiety by pediatricians until someone even reaches their teenage years when I see them. Of course, that still gets written off as anxiety. And then somebody say, okay, well, maybe you try to document this. Then they find, gosh, their heart rate goes to 180, 200 beats per minute. Then they decided, well, that's a little bit abnormal. We should look into it. And you look back, they may be even treated with anti-anxiety medication for a decade before that gets cured. And so they may present as palpitation, shortness of breath, but sometimes even completely asymptomatic, meaning that some people are not aware of the fast heart rhythm, fast heartbeat, and they become just more short of breath. And sometimes they don't come into us until the heart has completely gone into heart failure and the heart muscle has really just tired out. In an entity, what's called tachycardia-induced cardiomyopathy. Well, as a long term, basically, all that is saying that is that the heart muscle is really tired out from beating so fast and cannot keep up with the overall heart demand and the body demand. So the first presentation is congestive heart failure.
The cause. The cause. Tachycardia is caused by something that disrupts the normal electrical impulse that controls the rate of your heart's pumping action. Many things can cause or contribute to problems with the heart's electrical system. These factors include damage to heart tissues from heart disease, abnormal electrical pathways in the heart present or built, disease or congenital abnormality of the heart, anemia, exercise, sudden stress such as fright, high blood pressure, smoking, fever, drinking too much alcohol, drinking too many caffeinated beverages, medication side effects, abuse of recreational drugs such as cocaine, imbalance of electrolytes, mineral relaxed substances necessary for conducting electrical impulse or oversteroid and oversteroid hyperthyroidism. Treatment. Treatment for sudden onset occur episodes. When episodes of supraventricular tachycardia (SVT) start suddenly and cause symptoms, you can try vagal maneuvers such as gagging, holding your breath, and breathing down, basal maneuver, immersing your face in ice cold water, or coating. These simple maneuvers stimulate the vagus nerve, which can slow the conduction of the electrical impulse that controls your heart rate. Your doctor will teach you how to do vagal maneuvers safely.
Hey guys. This video will introduce you to the Valsalva maneuver. Now, the Valsalva maneuver is something that we're all familiar with, we're just not familiar with the name. What it is it's the bearing down feeling. It's when you try and pop your ears after getting off an airplane, or you get out of the pool and you want to pop your ears. That's what the Valsalva maneuver is. It's that bearing down, where you're holding your breath, you're keeping your air internalized, and you're pushing, just like when you have a bowel movement. It's one of those things that everyone knows exactly what it is, but it's very hard to describe in words, especially without getting awkward. So, just know that the Valsalva maneuver is essentially you trying to have a bowel movement. Now, why it's important is in cardiology, the Valsalva maneuver has two different applications. The first of which is it increases the parasympathetic activity of the heart. And why that's important is because it can be used to treat supraventricular tachycardias, or SVTs. Now, this is something that is obviously cheap and easy to do. You can do it at home, or if you go to a clinic or hospital with some sort of bounding heart problem, they might ask you to try doing this Valsalva maneuver. If you're having heart palpitation, you feel that heart just beating out of your chest, and you have a history of SVTs, one thing I want to try is just holding your breath and pushing down, really bearing down. That might be able to treat that without ever going to see a practitioner. Also, as I mentioned, it has another use here in cardiology, and that deals with the blood supply. So we talked about the nerve supply, the nervous system kind of treats those supraventricular tachycardias. However, it also has a blood aspect to it. This is much more diagnostic than treatment. This Valsalva maneuver can be used to diagnose things like hypertrophy of the heart, or where one side of your heart is enlarged. It also can be used to diagnose things like regurgitation through the valves, or valve prolapse, or valve stenosis. You might have heard things like that before if you're a practitioner. And what happens when you bear down like that is increase the pressure. And that kind of, since you have that increased pressure in your chest, it tells the blood not to come back to the heart. It says, look, we got a lot of pressure, there's no room for you, you can't come in. And what we call that in cardiology is the decrease of preload to the heart. Now, if you're a student of cardiology, you probably recognize preload as one of those Frank Starling terms. And preload is essentially, as the blood goes into the heart, it stretches the heart muscle passively, and it allows that heart to contract better. And to a certain extent, in 90% of cases, as preload increases, the efficiency of the heart, the beat of the heart is going to be more efficient. So in this case, since we're decreasing that preload, we're going to be decreasing the efficiency of the heart. And what this does is, especially when you have an echocardiogram, which is a test that we'll talk about a little bit later, if you decrease the preload, you're going to be increasing some problems in your heart and decreasing others. What you're going to be increasing is you're going to be increasing the hypertrophic cardiomyopathies, the times your heart's really big. If you do the Valsalva maneuver during an echo or during when someone's listening to your heart, that murmur, that hypertrophic murmur is going to be much louder. Now, if you do it and you have a valvular stenosis, meaning a narrowing,
or valvular regurgitation, meaning that that valve is incompetent, it can't hold the blood on the other side of it like it's supposed to.
Medicine shows. For several symptoms such as chest pain, shortness of breath, or feeling fine, you may be given fast-acting antiarrhythmic medicines by heart professionals in the hospital emergency department, where your heart can be monitored. Fast-acting antiarrhythmic medicine commonly used to slow the heart rate during an episode include adenosine, calcium channel blockers, beta blockers. Long-term use of an antiarrhythmic medicine might also be needed to reduce the chance of having more episodes of supraventricular tachycardia or to reduce the heart rate during these episodes. Common medicine used for this purpose include beta blockers, calcium channel digoxin. Advantage. The short-term management and long-term management. The short-term management. In most patients, the drug of choice for acute therapy is either adenosine or verapamil. The use of intravenous IV adenosine or the calcium channel blocker verapamil are considered safe and effective therapies for controlling supraventricular tachycardia. The advantages of adenosine include a rapid onset of action, typically within 10 to 25 seconds via a peripheral vein. Short heart less than 10 seconds, and a high degree of efficacy. The short half-life of this IM minimizes the severity of adverse effects, which include faster flushing, chest tightness, dyspnea, and transient sinus arrest and of atrioventricular growth. The use of adenosine is contraindicated in those patients with sinus node dysfunction or second of degree broad and short view used with calcium in patients with severe obstructive lung disease. Verapamil's efficacy is comparable with adenosine, but its negative nootropic effects, vasodilatory effects, and prolonged heart life make it unsuitable for patients with congestive heart failure or for those patients classified as hypotensive. Adenosine and calcium channel blockers are contraindicated for use in patients with Wolff-Parkinson syndrome. The long-term management, the pharmacology agents commonly used in the long-term management of supraventricular tachycardia includes amiodarone, procainamide, calcium channel blockers, diazepam and verapamil, and beta blockers como metoprolol or tenolol. The research reports that for chronic oral AV noradrenaline, the use of calcium channel blockers and beta-adrenergic blockers is preferred and has been shown to improve symptoms in and 60% to 80% of patients.
The second arrhythmia is called AV node reentrant tachycardia. So I'll just shorten that by TAC. So the AV node is the electrical bridge in the lower that connects the upper and the lower chamber that sends the impulse down to the lower chamber. This particular bridge actually has two components to it. This is going down to the lower chamber, and this is the bridge right here. This is the bridge right here. And so there are two entrances to this bridge, in a way. A short one, which gets the impulse down very quickly to the lower chamber, and kind of a long one where the impulse takes much longer to get down to the lower chamber. And that's normal. Everybody basically has these two pathways. Occasionally, and for unclear reasons right now to us, these two paths can form a circuit that will cause the impulses to travel around the circuit in a rapid way. Typically what happens is that the normal impulse comes down through the fast pathway, gets down to the lower chamber quickly. It also gets down to through the slow pathway, but because the slow pathway is so slow, by the time it arrives here, the impulse has already gone down, so it doesn't have to do anything else. However, there are times when some sort of extra beats can come along. Let's see, an extra beat comes along, and it doesn't go down the fast pathway. It blocks there. And then it goes down the slow pathway. It takes a little longer time, and then it gets down to the lower chamber through the slow pathway, kind of the backup pathway. What happens is that when that impulse arrives at this Y right here, there's no impulse coming down that way, so this short bridge is open. The impulse not only goes down this way, but it also goes up this way. Spreads both directions. And then on the right, right circumstances, it can come back up into the upper chamber via that fast, short pathway, and then spread through the upper chamber. But what happens when it spreads through the upper chamber is that it also comes down the slow pathway again. And once this starts happening, it can keep going around in a circle like this. And essentially, it is going around in a circle right very near the bridge in this short, small area over there. And this goes around much faster than the natural pacemaker is going. And so it is now driving the heart at a much faster rate. And these rates can vary from a little over 100, maybe 120 beats a minute or so, all the way up to 250 beats a minute type range. It all depends on how slick this pathway is, how much adrenaline is going on to allow it to go fast, and so on. So that's another type of supraventricular tachycardia.
Tense.